Bismillahirrahmanirrahim. Today we will discuss reactive rhinitis and nasal polyps. Reactive rhinitis, it is a rhinitis without infection, just inflammation in the nasal mucous membrane without infective microorganism. It divided into allergic and non-allergic or vasomotor reactive rhinitis. Regarding allergic rhinitis, it's defined as antigen-antibody reaction or type 1 hypersensitivity reaction, immunoglobulin E mediated, in the nasal mucous membrane, leading to the characteristic symptom of nasal allergy, which is characterized by itching, sneezing, which is very characteristic for allergy, plus the actual clinical picture of any rhinitis, nasal congestion, and nasal discharge. But here, rhinorrhea is watery rhinorrhea. Regarding the type of allergic rhinitis, according to the season, it either seasonal, occur in certain season, like hay fever, like in Egypt during Khamaseen wind in March and April, or perennial, occur all over the year. This is limited by the presence of the antigen. If the antigen is present all over the year, okay, it will be perennial. But if it is only appear in seasons, so it is seasonal. Although regarding the etiology, it need allergen, it need the causative antigen, which named here allergen, but it may be genetically inherited, and in this case, it appear in children, blue 5 years or 10 years, appear maybe after 2 or 3 years. It's in this case called atopy due to inherited tendency. So it can run in family due to genetic inheritance, but not all case of allergy. Regarding the antigen, here we are discussing about respiratory allergy. So the main type of allergen will be by inhalation or inhaled, and there is a very common allergen inhalant is the pollen, dust mite, and animal dander and feathers. This is very common type of inhalant allergen, but anything can develop allergy in the nose, including chemicals, perfumes, anything can be inhaled and can lead to allergy. This for the first type, which is inhalant and is responsible for nearly about 70 up to 80% of allergic rhinitis. Second type is the ingestant, and the ingestant can lead to specific type of allergic rhinitis after eating some food, namely egg, milk, fish, shellfish, peanuts, strawberry, tree nuts. After eating this, the patient will complain by the itching in the nose and in the throat also, and it's very characteristic. And the patient will develop also something called allergic pharyngitis, in which he can feel some sore throat after eating some type of food like mango, like nuts, like yogurt. And of course, this is not infection; it is due to allergy. He feel like pain in the throat after eating this, and he want to do itching in the throat and in the nose. The third type of allergen is the drug, and any drug can cause allergy. But here we are specifically focused on the antibiotic, namely the penicillin, and non-steroidal anti-inflammatory, namely the salicylate, which is very common in causing allergy. Regarding the pathophysiology of allergic rhinitis, we have two phases of exposure. First exposure and re-exposure or second exposure. During the first exposure, the allergen have to be introduced into the serum, into the blood, to the P lymphocyte to produce a specific clone of P lymphocyte which produce specific immunoglobulin E for the specific antigen. So each antigen has its specific immunoglobulin E antibody. This immunoglobulin E antibody will be attached to the surface of the mast cell. Where is the mast cell? Mast cell is a specific type of macrophage situated in the body orifice, in the skin, in the conjunctiva, in the nasal mucosa and respiratory mucosa, and that's why this is the site for allergy. We have allergy in the skin, allergic dermatitis, we have allergy in the eye, allergic conjunctivitis, we have allergy in the nose and in the respiratory system, rhinitis and bronchial asthma, and that's why this is the area in which allergy occur because it contains a mast cell in the submucosa and in subdermis. In the re-exposure or the second phase of exposure after the body know the antigen and develop the antibody for it, here the antigen antibody reaction occur at the site. No need to enter the blood, just in the nasal mucosa, in the skin, the reaction can occur at the surface of the mast cell antigen and the antibody leading to what's called mast cell degranulation. The granule in the mast cell, which contains the histamine and the prostaglandin, leukotrienes, neuropeptides, tryptase, and eosinophilic chemotactic factor, all this mediator will be released and can cause the clinical picture of the allergic rhinitis. How? As you know, the histamine is the most potent vasodilator in the body. And that's why if we have a severe allergy, like anaphylaxis, if you give an antibiotic shot to the patient and he develop anaphylaxis, you will have this patient will develop a drop attack. He will suddenly drop down because the blood pressure will become zero because it is the most potent vasodilator, the histamine. So histamine can cause also here a vasodilatation in the nasal mucosa with a vasodilatation, increase in the capillary permeability and leading to the what's called increase in the transudate. That's mean watery discharge, no muco or mucopurulent discharge because no activity in the goblet cell. So it's just a watery discharge. The second thing that the histamine and the other mediators are nerve irritant. This lead to itching and sneezing, which is very characteristic. Of course, the vasodilatation also can lead to the nasal obstruction. So that's why the clinical picture of allergic rhinitis developed through the mediators. Allergic rhinitis is a very common disease. It affects up to 30% of population, but not every patient with allergic rhinitis have a major problem. Because many patients have a mild type of allergic rhinitis, which doesn't interfere with normal daily activity. It appears less than 4 days per week, less than 4 weeks per year. So there is no much problem. Even take some medication, antihistaminic or something, and he will be okay and fine. The other type, which is the moderately severe, also they are less in number, but it is an economical burden. It's a very common problem. And then in this patient, a persistent symptom if appear, it do impact in his life, interfere with his normal daily activity. Imagine patient wake up in the morning, he is have a sneezing attack up to 1 or 2 hours. He has always water rhinorrhea, itching. He cannot go for work. This is a persistent symptom, more than 4 days per week and more than 4 weeks per year. Regarding the clinical picture of allergic rhinitis, symptom and sign. Symptom, very common sneezing, which is very characteristic. Itching, not only for the nose, but also for the ear, for the eye, and for the soft palate. Runny nose, meaning watery rhinorrhea, no mucus in the discharge, nasal congestion, and postnasal trip due to increase in the amount of the nasal secretion, watery secretion, and the patient can feel it postnasally. Regarding the sign, we have general sign and local sign. General sign mean complexion. When you see the patient coming to your clinic, you can diagnose he has a allergy by looking on his face. Two sign very important in the face of allergic patient. Allergic shiner, that means dark circle surrounding the eye in the upper and lower eyelid related to vasodilatation and repeated itching for the eyelid. The second thing is the nasal crease or allergic salute, which is the horizontal crease on the dorsum of the skin of the nose due to recurrent rubbing of the tip of the nose by the palm of the hand. So this can develop these two characteristic feature in the face of allergic patient. Regarding local sign, it's very characteristic to see this color of the inferior turbinate or the nasal mucosa. It's blue, blue gray mucosa with a thin discharge, water discharge, and you feel the turbinate like a sack filled of water. That's actually due to the inferior turbinate swelling is formed by the fluid come from the blood vessel and from the vasodilatation of blood vessel. So that's why it's appear like pale bluish due to the color of the blood vessel dilated and due to a lot of fluid. So it is in the contrast to the in case of chronic hypertrophic rhinitis in which the turbinate is red, here is the turbinate is blue, and this is characteristic for the color of the mucosa of the nasal turbinate and of the nasal mucosa. This color is characteristic for allergic rhinitis. Regarding investigation, of course, uh, the investigation is not done to diagnose allergic rhinitis. The patient already will be known that he got allergic rhinitis. You can diagnose it whether clinically or by history. So it's easy to diagnose allergic rhinitis. Investigation here is not to diagnose allergic rhinitis, but to diagnose the antigen. So we need it in severe case if there is a resistance. Um, to diagnose a type of antigen. So this is what's called allergy workup. Allergy workup includes skin sensitivity test, the standard workup in the allergy, it's skin prick test. This skin prick test, we inject the possible antigen, whether by syringe, like insulin syringe, intradermal, or by a scratching method. Just a scratch, and we put the antigen inside the dermis, not subdermal, to avoid making a blip. Then we will wait and see the reaction of the body. If wheal and flare, that mean edema, blip, and redness and congestion surrounding, occur, so the patient is sensitized to this antigen or allergic to this antigen. If not, the patient will only have just the site of injection or the site of scratch, but nothing around it. So this is the standard workup for testing the allergic rhinitis. The other test is a nasal challenge test or nasal provocation test. It's done by using the suspecting antigen as a spray. We can put it applied in the nose, causing the patient sneezing and rhinorrhea. It's less invasive, but it's less specific. So it is could be used to avoid the invasion or uh, a lot of pricking to the skin. Skin sensitivity and nasal propagation test is not pathognomonic, but the pathognomonic test is the serological because it's lab test. We test the total immunoglobulin E level. If it is higher, so that means it is allergic. But if we need to know the specific antigen antibody, we need to know the specific antibody level for the specific antigen. This by RAS test. This is a pathognomonic. If we have a high level for immunoglobulin E for the dust mite. So this mean that the patient have allergy to dust mite. So the pathognomonic test for allergic rhinitis is the RAS test. Okay, radio allergosorbent test. Treatment for allergic rhinitis is like step ladder. Okay, we have to do counseling for the patient. This problem is will continue with you if you have this antigen, you will develop allergy. So avoidance of the antigen will not develop the allergy. But if you exposed to the antigen, you will develop the allergy, and this is for your lifetime. We can give you treatment which can suppress this reaction. This is not surgical disease; it's a medical disease. The treatment can be taken in a bouts, in a cycle, up to 3 or 6 months per year, accordingly. And surgery only applied if there is a complication occur. And the complication for allergic rhinitis is only chronic hypertrophic rhinitis and nasal polyposis. So it's medical except in complication. The first line of treatment is allergen avoidance, and this is the best line for treatment. It is 100% success if we can to do it, if we can do it, because it is not always possible. Allergen avoidance means that you avoid the antigen. So that means you need to know the antigen, and it's not an easy way because many patients has a multifactorial, not only one antigen. The other thing is that if we know the antigen, but we have some socioeconomic problem. If you live in one city and this city have a specific antigen, but you need to live with your family, you cannot go away from the antigen. So allergen avoidance is a 100% success. If you have allergy to strawberry and avoid strawberry, you will not have an allergy. But it's a problem in allergic rhinitis more than this because it's multifactorial and there is also socioeconomic burden. Second line for treatment is pharmacocerebral medical treatment. It's very important. It's the main line of treatment till now. It includes a lot of drugs, group of drugs, antihistamine, decongestant, steroid, muscle stabilizer, and the patient have to know each type of treatment and when he use it. You should avoid the complication of this type of drugs. All of these drugs have systematic form, local form, systematic form in the form of oral tablet and injection, and the local form in the form of spray or drops. The antihistamine and steroid are the most commonly used and the most safe type if they are using in a good manner. Antihistamine have an old generation which can cause sedative and CNS suppression effect, but the newer generation is a very good, cannot do this sleepiness. Antihistamine is one of the most commonly used drug for treatment. But we should know that the patient should take antihistamine in a cycle treatment, in not a continuous line of treatment. You can use it for 2 weeks or months, then you can stop when the condition improved, then return back to it when you need it. No need for long course of antihistaminic because it have some side effects, especially the newer generation like arrhythmia, something like this. So avoid the long use of antihistamine. The local type of antihistamine have some effect like Zalastin and Levostin. It can be used also in some case, especially if combined with allergy in the eye. Decongestant, which is a very commonly used drug, but it has had a lot of side effects. The local drops, like all most commonly used drops, like we use it, like Brusolino, Trevine, Afrin, it's very effective for decongestion because it's a sympathomimetic and can cause vasoconstriction. It decreases the blood supply and lead to the decrease the obstruction. But the problem is that the decongestant, local decongestant, can lead to what's called tolerance, because the receptor of this decongestant will increase by use, and in this case, the patient at first only 1 or 2 drops can make his nose open, but after that he will need up to 150 drops or 100 drops. This is called rhinitis medicamentosa, and this is one type of vasomotor rhinitis, as we can see after. The systematic decongestants, like most type of cold medication and cold remedies, contain a very dangerous drug, some vasomimetic, which can lead to increased hyper blood pressure, can lead to increased intraocular tension and glaucoma, especially in old age, and can lead to prostatic congestion in old male. So it's avoided in old age group of above 40-45 years, because it has a lot of side effects. Steroid, we have local and systematic steroid. Steroid also is a very wonderful drug in treatment of allergy, decrease the immunological cascade, and also it is anti-edematous, anti-shock measure. It's a very wonderful drug, but have a lot of problem. It's avoided in hypertensive patient, diabetic patients. It can lead to some sort of osteomalacia. So we should use it locally better than systematically, except in severe case or combined case with bronchial asthma. Local steroid is very effective. Of course, it's not as rapid in action like decongestant, but it can give a good result after 1 week or 2 weeks. You need to explain to your patient that the local steroid is safer than the systematic steroid or than the decongestant, and you will be very good after some time. Muscle stabilizer is a drug that prevents the degranulation of the muscle. It includes local drugs like chromoglycate, and includes systematic drugs like ketotifen, namely like allerban or something. It's a very good drug, and it can be used in severe case of allergic rhinitis. This tone summarize the problem of long prolonged use of antihistamine, which can lead to severe arrhythmia. This to avoid the prolonged use of antihistamine. Third line of treatment is the immunotherapy. Immunotherapy is what's called, it's lead to desensitization of the antigen by forming what's called the blocker or blocking immunity by forming immunoglobulin G and immunoglobulin A, which prevent the antigen to join its receptor in the mast cell. This occurs through what's called desensitization. How? We inject the antigen either intradermal by scratching method, as we talked before, or even sublingual by gradual increasing in the concentration of the antigen, leading to the development of the blocking immunity, and which will prevent the severe allergic rhinitis clinical picture. It have some improvement, but still the medical treatment is the first line. But it could be very helpful, especially in combined type of allergy when there is a bronchial asthma with allergic rhinitis. This patient need something more than just medical treatment in many cases. As we told before, surgical treatment is only for complication or sequelae. If we got sinusal polyposis, we treated with endoscopic polypectomy. If we got chronic hypertrophic rhinitis, we treated with inferior turbinate reduction maneuver. So surgery only for complication. But allergic rhinitis is a medical disease. Second type of reactive rhinitis is a vasomotor rhinitis. It's also a very common, like allergic rhinitis. It's abnormal reaction in the nasal mucosa without allergy. Normal reaction for what? for many things. Vasomotor rhinitis, by name, it means that there is abnormality in the blood vessel tone in the nasal mucosa. Normally, there is a tone or a balance between the parasympathetic and sympathetic. We have something called the nasal cycle, in which we have in each side of the nose, we got parasympathetic taking upper hand in the, namely, for example, left side. So the sympathetic will take the upper hand in the right side. And after 20 to 25 minutes, it will changing position. So the sympathetic become in the left and the parasympathetic in the right. This normally the occur without feeling. We cannot feel it, except if we have something like a common cold, especially in the first day. You can feel that one side is obstructed and the other side will obstruct. It's just exaggeration of the nasal cycle. So this is the normal tone. The theory for vasomotor rhinitis, we got two theory. The neurogenic theory, in which there is imbalance between the parasympathetic and sympathetic, making the parasympathetic taking the upper hand, leading to vasodilatation, congestion, obstruction. So the main clinical picture will be nasal obstruction, and what nasal discharge will be watery discharge also. So we have a blocker or dribber. Blocker means nasal obstruction, and dribber we have rhinorrhea, water rhinorrhea, which, by the way, is a more aggressive symptom because it can interfere with normal and social life. What is the cause? Environmental. Environmental means that extreme of temperature. If you have a cold air, something like this, patient complaining of nasal obstruction and water rhinorrhea. If we got an hot weather, severe hot weather, also patient can complain with this. If we have what's called gustatory rhinitis, occur when we eat an hot meal, when we eat hot meal, hot soup, something like this, you feel like rhinorrhea and nasal obstruction is a very common problem. This is called the gustatory rhinitis. Emotional during stress, during examination. By stress can lead to nasal obstruction, watery discharge. So this is the problem. Other cause drugs, rhinitis medicamentosa with the prolonged use of vasoconstrictor drugs like atropine, afrin. Then the other theory, which is the endocrine. Endocrinal means that estrogen and progesterone. By estrogen increasing the vascularity of the nasal mucosa and the regeneration of the nasal mucosa. So that's why during pregnancy, it's called gestational rhinitis, which occur in the first trimester and they can continue till delivery. That means that during increase in estrogen leading to nasal obstruction, and this is one type of vasomotor rhinitis, endocrinal. It also with the oral contraceptive also occur at the age of menarche, menstruation. It's related to the hormone, namely the estrogen. So we have two theory: neurogenic through parasympathetic imbalance, and the other theory is endocrine through estrogen. Clinical picture, as I've said, it is nasal obstruction and nasal discharge, blocker or dribber, and the dribber is a more serious problem because it has a lot of social problem. Management, it is similar to the allergic rhinitis. It have two sequelae also: chronic hypertrophic rhinitis and sinusal polyposis, and this is the only surgical complication. Regarding treatment, same medical treatment but without the use of antihistaminic. Here we can use steroid. Here we can use decongestant. Here we can use anti what's called parasympatholytics, like ipratropium, which namely Atrovent. We can use it to decrease the parasympathetic supply. Also, in dribber, patient have severe watery rhinorrhea and have a severe problem, we can use what's called video neurectomy. We can cut the video nerve to decrease and cause dryness to the nasal mucosa, of course, in severe case of vasomotor rhinitis. Of course, if we have surgical sequelae like chronic hypertrophic rhinitis and sinusal bulbosis, we can deal with it by surgical treatment. Then we will shift to the other part of the lecture, discussing about the polyps. We have two types of polyps, sinusal bulbosis and antrocanal polyp. Sinusal bulbosis is the right name because it's not a nasal polyp, it's a sinonasal polyp because it is appear from the sinus mucosa, but this sinus mucosa enlarged in size and go inside the nasal cavity, so we can see it in the nose, but its origin from the sinus, so the better name is a sinonasal polyposis. It is a pedunculated prolapsed edematous sinonasal mucosa. Of course, it's covered by the respiratory epithelium, but if it is exposed to the air, it can be transferred to the squamous epithelium by squamous metaplasia. We discuss about the pathogenesis of this polyp. It starts with obstruction of the sinus ostium, leading to decrease the pressure inside the ostium, leading to edema in the sinus mucosa, then prolapse of the sinus mucosa, prolongation of the sinus mucosa till it reaches to the ostium of the sinus, through which it passes and have strangulated inside the ostium, then become pedunculated and it appear in the middle and superior meatus. So that's why it is a sinonasal, not nasal polyps. We have classification to the polyp. If it's go outside and appear in the middle meatus, type 1. If it go outside the middle meatus, just outside the middle meatus, it's called type 2. If it's between the middle inferior turbinate and the nasal septum, it's type 3. Or if it's appear in the nostril, it's type 4. The most common sinus to be affected with the nasal or the sinusal bulbosis is the sigmoid sinus. Why? Because it's formed by air cells, not a large sinus cavity, and each air cell has its ostium, so it is the most common sinus to be affected with sinusal bulbosis. So regarding etiology of sinusal bulbosis, it appears in allergic rhinitis, vasomotor rhinitis, sigmoiditis, allergic fungal sinusitis, also in cystic fibrosis, in which it is autosomal dominant genetic disease leading to formation of nasal polyp and cyst in the lung. It's due to deficiency in the protein activate the sodium channel in the cell wall, leading to accumulation of chloride and sodium inside the cell and leading to what's called cyst in the lung and polyp in the nose. It's a potentially fatal disease, and the polyp will be appear in the child period in childhood. So it's not common in Egypt, alhamdulillah, but we have another disease which can lead to polyp in children, like ciliary dyskinesia disease or ciliary motility syndrome, what's called the Young syndrome. We have Cartaginer syndrome, in which there is recurrent bronchiectasis, and we have dextrocardia beside the sinonasal polyposis. The sinusal polyposis mainly appear in the middle age group, but if it appear in a child, we should suspect something like ciliary motility syndrome or Cartaginer syndrome. Regarding the clinical picture of the sinusal proboscis contain all the clinical picture in the nose on the rhinology by mean that nasal obstruction, which can be partial, complete, unilateral or bilateral. This can appear in the first unilateral, then become bilateral, no problem. Regarding smell affections, appear with hyposmia, then it can lead to anosmia. Regarding nasal discharge, according to the etiology, it could be watery in allergic and vasomotors, could be burnt, mucoburnt, like in sigmoiditis. It could be mud, like in allergic fungal sinusitis. So any type of discharge can appear. So All type of clinical picture can occur with sinusal polyposis. The golden investigation is the CT, paralyzar sinus. Regarding treatment, here we discuss about medical and surgical treatment. Medical treatment, especially if in stage 1 or 2, this can be okay. And here we rely on steroids, whether it is local or systematic. And also we can add the antibiotic in case of smallditis can help. We can add the antihistamine in the allergic rhinitis. This is a medical treatment. What about surgical treatment? We mainly depend on endoscopic sinus surgery. We clean the sinus from the polyp, open the sinus for drainage, and we can apply the medical treatment in these open sinus. The other type of polyp we discuss is the antrocanal polyp. By the name, it is a polyp appear in the antrum, mainly the main here, the maxillary antrum, reaching to the guana. So it's appear in the antrum of the maxillary sinus and it pass through the middle meatus posteriorly till it reach to the guana to obstruct it. Or even if it is neglected, it can be enlarged till it reach to the nasopharynx and obstructing the nasopharynx. This is what's called antroguanal polyp. Regarding the age of this patient, appear in adolescence, a younger age group than the sinusal bulbosis, and it really appear after 30 years. It's mostly between 10 to 20, 25, maximum to 30 years. Etiology unknown, but it's mostly due to retention theory, due to obstruction in the in the ostium of the maxillary sinus, leading to a decrease the pressure and pedunculation of the and the prolongation of the maxillary sinus mucosa. Regarding the other theory, it's inflammatory due to the presence of inflammatory mediator in the pathology, but still unknown theory. The most important thing about the antrocanal polyp, it is one unilateral nasal obstruction discharge. It appears in the differential diagnosis of unilateral nasal obstruction and unilateral nasal discharge. So we need to know what's the other cause differential diagnosis for unilateral nasal obstruction, for unilateral nasal discharge, and this is very important. As regard investigation, CT paranasal sinus is a gold uh, type of investigation. Regarding that treatment, surgical treatment, only surgical treatment, no need for medical treatment at all. So surgical treatment is the only line for treat antrocanal polyp by endoscopic sinus surgery, or in the old way, we can use what's called Caldwell lock surgery. It's appeared by sublapel incision. We open the anterior wall of the maxillary sinus, we get inside the maxilla, remove the polyp, and we can do the middle metal antrostomy. We can use it till now in the multiple recurrent case, but most case is treated by the functioscopic sinus surgery. As you can see here, this is the antrocanal polyp. You can see the part in the maxilla, which is a large part. Then the part passing through the choana is a posterior part. This is the maxillary ostium sinus and the type of polyp. Thank you.